we'll start. Okay, let me put on my slides.
So, hello everybody. I didn't say hello to everybody, so nice to meet you again.
I think we're online.
Okay.
Okay, let me put my slides. Let me put my slides. Can you see my slides, Sumaya?
Yes, Dr. Hassan.
Let me. Can you see it now?
Yes.
Yes.
Okay. All right. Good evening, ladies and gentlemen, and welcome to this webinar entitled Office Hysteroscopy and Update. I want to welcome you all, but more importantly, I would like to welcome our international speakers who have taken out of their time to be with us today and share with us their vast experience and their great knowledge to be with us today. This webinar is organized in collaboration with the Middle East Fertility Society. As you know, our board committee in Cairo in Egypt is formed of 4 fellows and 4 members, and my humble self as chair, Professor Gasser al-Bishri, Abdelnisa Khan, Ahmed Zakaria Sheikha, Hassan Abu Makarim, and Dr. Wafam bin Benjamin, Dr. Ahmed Mustafa, Dr. Miham Hawani, and Dr. Samah Salama. They also work in collaboration with the UK Egypt Liaison Committee headed by Professor Mohammed Al-Fattah, who is a professor of urogynecology in Aberdeen. We also collaborate very much with our predecessor, our previous committee headed, which was headed by Professor Amr Elnoury, who is with us tonight. I want to start by welcoming Mr. Martyn Underwood. Mr. Underwood is consultant gynecologist and medical director. He is also colposcopy and hysteroscopy. He's the colposcopy and hysteroscopy lead of the Women and Children Care Group at Shrewsbury and Telford National Health Service Trust. He performs more than 2,000 procedures every year, and he has already trained more than 100 consultants in surgery master classes that he organizes frequently. He is a senior research fellow at the University of Birmingham. We thank him very much. We welcome him. He's going to talk to us about implementation of office endometrial ablation. I would also like to welcome our former colleague, Mr. Ayman Ewies, who is consultant gynecologist and again at Sandwell and Westbury Birmingham Hospital in West Midlands in the UK. He's an honorary senior lecturer at the University of Birmingham. He's the deputy academic lead for year 3 and lead of professional development activities module. He has the educational resources advisor, which includes the core e-learning, the continuous professional development e-portfolio, the training e-portfolio, the website resources for the Royal College of Obstetricians and Gynecologists in the UK. He's also the associate editor of the Journal of Obstetrics and Gynecology. And tonight, he is going to talk to us about office hysteroscopy, from general anesthesia hysteroscopy to see and treat. I would also like to welcome and thank Sister Sara Greenaway, who is a clinical nurse specialist and nurse hysteroscopist, and a colposcopy and hysteroscopy. And I think this is the global software professional and deputy manager of Sandwell Hospital at the Alpha Suite at Sandwell and West Birmingham Hospital. She's going to tell us about the role of the nurse hysteroscopist in the modern practice in the UK. And finally, I would like to thank and welcome our dear colleague and friend and former chair of this committee, Professor Amr Elnoury, who, as you all know, is professor of obstetrics and gynecology at Cairo University and the Laser Institute. He's a former chair of this committee, the Egyptian Representative Committee of the Royal College in Egypt, and he's a board member and honorary treasurer also of the Egyptian Society of Gynecology and Obstetrics, the ESCO. He's going to talk to us about hysteroscopy and infertility and the safety measures in this context. And From Lebanon, I would like to welcome our dear friend and colleague, Professor Michel Abu Abdallah, who is going to be my co-moderator tonight. As we know, Professor Abu Abdallah is the head of the Middle East Fertility Clinic in Beirut in Lebanon. He's a former fellow of McGill University in Montreal in Canada in reproductive endocrinology, infertility, and andrology. He's of course a co-founder, president, and executive director of the Middle East Fertility Society and a member of the American Society for Reproductive Medicine International Committee. I would like to thank him or welcome him. And also I would like to remind our attendees, who I understand now there are over 1,000 registrations this morning, to put the questions and answers not in the chat section, but in the questions section. And I would like to thank Merck Pharmaceuticals for sponsoring this activity tonight. And now I will switch my microphone and my video to Professor Abu Abdallah, who is going to tell us about the Middle East Fertility Society. Michel. Professor Abu Abdallah.
You hear me?
Yes, we do.
Okay. Good evening, everybody. Hassan, this is our 4th webinar together. And they've been very successful. The cooperation is excellent. The programs were highly appreciated by the audience. And I think we should go on in providing platform of education for our colleagues in the Middle East. I'm pleased and honored to co-chair with you this webinar tonight. And on behalf of the Middle East Fertility Society, I would like to welcome the speaker as well. And we all here to listen to the most interesting data tonight. Thank you again.
Thank you, Professor Abu Abdallah. And with this, I will cede my microphone and my my video to Mr. Martyn Underwood. Please, Mr. Underwood, the floor, the microphone, all is yours.
I hope everyone can hear me.
Yes,
to make it clear, so there's 2,000 procedures in our unit, but I don't do them all. I do have a few colleagues that help me. So I've been asked to talk about endometrial ablation. I'm mainly going to focus on the outpatient setting, and we'll go through what that means shortly. I'm a consultant in Shropshire, working in a busy obs and gynae unit, and as West Midlands trainee, so I've spent most of my time in the West Midlands. From the declarations of interest, I do run master classes, which are hysteroscopy sessions by a company called Hologic, so I just need to be clear about that. So we're going to run through what is ambulatory gynecology, why would we do this, what our appointment times and schedules are, which patients are suitable for outpatient ablation, how we would do the ablation, and then the evidence of whether this works. So ambulatory gynecology is any procedure performed while the patient is awake. We utilize the outpatient setting and resources to deliver this. Some units will call this one-stop clinics, and in America, they'll call this office gynecology. There will be variation between units and what's offered, but it can all be developed with time. And I understand that present in Egypt, you haven't fully embraced the ambulatory gynae care pathway, but I suspect it's something you may wish to develop in the future. So why would we offer ambulatory gynecology compared to general anaesthetic procedures? Well, there's a great deal of evidence to show that it's much safer for patients with lower complication rates. The complication rate for a general anaesthetic is up to 5%, whereas an ambulatory procedure, it's less than 0.5%. There's less hospital-acquired infections and less VTE, which is thrombosis. From the patient's point of view, they have much less time off work. So if they have a simple hysteroscopy, they can go back to work the same day or the next day if they feel up to it. If they have an endometrial polypectomy, we'd tell them to have 24 hours off work, and an endometrial ablation is 24 to 48 hours off work. If we compare that to a resection of the endometrium under a general anaesthetic, the patient could be off work for up to a couple of weeks, so they are back to everything much quicker. There's no need for a pre-op. We don't need to do any blood tests or anything for these patients coming in for the procedure. And there's no need for a general anaesthetic. UK practice, if you offer a general anaesthetic today, is that they shouldn't drive and they need a family member to stay with them for 24 hours after the procedure. And we avoid the need for all of that. In the UK, we also have much shorter waiting times if you're having a procedure whilst you're awake compared to in theatre. And the patients do get back to normal activities and work much quicker. The length of stay is significantly shorter. If they had a simple hysteroscopy, they can leave the building straight after the procedure, up to an endometrial ablation where we'll keep them for about 15 to 20 minutes after the procedure. All of these procedures are done with oral anaesthetic, and then we'll talk about cervical and fundal blocks shortly. And then from patient satisfaction, we do find a greater patient satisfaction for this. And part of this is that the patient can actually see the procedure being done and they can be part of the procedure, so they enjoy that more. From a hospital point of view in the NHS setting, the advantages are that you don't need any day case or inpatient beds. You can get more patients performed per operating list using less staff. And if the patients go down the see and treat route, you can actually have less clinic attendance. The downside, I'm afraid, is that this single-use kit is generally more expensive than the reusable resectoscopes that we would use in theatre. If we look back at NHS practice of hysteroscopy, back in 2014 to 15, the rate at that point was just under 60% of all hysteroscopies were performed under local anaesthetic, with a national target to achieve around 80%. In our unit, we're actually 98%, and across the UK, most units are over 90% of hysteroscopies are performed in the outpatient setting now. So there's been a significant uptake of this procedure. From our schedules, if we're doing a simple diagnostic hysteroscopy, we'll see 9 patients each morning. And if we're doing operative procedures such as endometrial polypectomies or ablations, then we'll do 6 to 8 patients per list, which is significantly quicker than a general anaesthetic theatre list. When it comes down to the costs, I've not gone into the money in a great detail because our practice and practice across the Middle East will be different. But generally, the single-use devices can be more expensive, but you do save on the use of staff, the room, and the number of people who are in theatre. If we perform a procedure in the ambulatory setting in the outpatients, you need the surgeon, a nurse or a band 3 or 4 junior member of staff to assemble the scope, and then another member of staff would be a healthcare assistant who has an important role as what we call the vocal local. And you'll see on the video shortly, their role is to distract the patient, and that offers a great form of pain relief. So you can see compared to a theatre, there's significantly less staff needed. Our local setup, we've got the Shropshire Women and Children's Centre on the back of Princess Royal Hospital in Telford in Shropshire. And inside, we've got 2 of these ambulatory care rooms, which have separate ensuite changing rooms and toilets, and a recovery bay. So to the right of the wall is the first room you've just seen, and to the left of the photo is the other colposcopy and hysteroscopy room. And you see there's no trolleys or beds in this area. All the patients go onto these chairs which can recline and do have wheels. So if the patient is feeling a little faint, we can wheel the chair in. But the expectation is the patient walks into the room and walks out the room 10 minutes later. So we offer endometrial ablation to pretty much everyone. The main thing to consider is their family does need to be complete. So if they're contemplating more children, then you should not be offering an endometrial ablation. You also need to inform the patient that they must use a form of contraception following this procedure, as the endometrial ablation is not a form of contraception. We would not offer an endometrial ablation to a patient that's had a previous ruptured uterus, uterine perforation, classical cesarean section, or a uterine anomaly. In that situation, we would offer a general anaesthetic resection of the endometrium, a traditional TCRE. Obviously, if they've got an active infection or there's any precancerous or cancerous cells, then we wouldn't offer an ablation in that group of patients. We often get asked about the number of previous cesarean sections, and we have no limit to the number of previous cesarean sections. And there are several papers published around the world, with the Mayo Clinic in America having the largest batch of data. And there are patients with 6 or more cesareans in that group that have had successful endometrial ablations without a complication. We also get asked about scanning the scar thickness as to whether we would offer this, and we don't need to do this for a routine endometrial ablation. Previously, those that offered microwave endometrial ablations were encouraged to measure the scar thickness, but with a more recent technology, this is no longer needed. Vast majority of our procedures are performed under local anaesthetic, and a small number of patients are performed under a general anaesthetic, and those are generally the patients that don't tolerate a speculum or a Propel biopsy in the outpatient setting that will request a general anaesthetic. Prior to an endometrial ablation, we'll take a Propel in the clinic to ensure that the endometrial biopsy is normal. We'll perform a pregnancy test on the day, and they will have been advised to use contraception for 3 weeks prior to the procedure, and consent would have been taken in the clinic and confirmed again on the day. We mentioned before, those that have significant anxiety or don't tolerate a pelvic examination, we'd offer those a general anaesthetic. As I say, the vast majority of our patients are performed under local anaesthetic. From local analgesia, we offer Oromorph, diclofenac, and a Dansatron prior to the procedure. The ideal time to give these drugs is around 45 minutes before you start the procedure, as that's their optimum use. We also do a routine intracervical block with 3 ampules of Cytonest, and then we do a fundal block, which I'll demonstrate shortly. We're using a Cook's-Williams needle, which goes down a 5 French channel on an operative hysteroscope. We normally ask the patients to hang around for around 15 minutes after an endometrial ablation before they go home, and we normally suggest that somebody else drives them home, but this is usually down to the use of Oromorph, which makes some of them a little woozy. They then have 24 hours off work, sometimes 48 hours, and we advise them not to use any tampons, have sex, or go swimming until the discharge has settled down. This discharge can last between 4 to 6 weeks after an endometrial ablation, and they will get abdominal cramp and discomfort for several weeks after the procedure too. And a lot of this is down to counselling of the patients. If you counsel them appropriately, then they won't come back. From the fundal block, we use a drug called Chirocaine down a Cook's-Williams needle, which is a long blue plastic tube with a metal needle, which is around 8 millimeters in length at the tip. We put 2 mils adjacent to each ostia and a further mil just to the left and right of the midline. And we do that at the start. So we would offer oral analgesia first, then do the cervical block, and then we would do a hysteroscopy to ensure the endometrial cavity is regular. And then we would do the fundal block, and then we would proceed straight on to do the NovaSure. This is a video of a patient having an endometrial ablation. You'll see the patient on the left is holding the hand of the HCA, who you may or may not hear is talking to the patient about holidays and children. We've actually videoed this procedure live as we were doing live video surgery, so there were some people in our lecture theatre watching this case. So you will hear me chatting to the patient as we go through. I'll just press play. So at the moment we're doing the cavity check, and this is distending the uterine cavity with CO2 to ensure there's no leaks or perforations. And initially there was a bit of a leak around the cervix, so I've adjusted the Valsallam. So now we've started the ablation, and a typical endometrial ablation in the UK will take between 30 seconds and 2 minutes. And it's performed under local anaesthetic.
Oh, it does.
So you see the lady's had an endometrial ablation. She's managed to talk all the way through the procedure, and she's given it a pain score of 2 out of 10, with 10 out of 10 being the worst thing ever and 0 being no pain. So from our data, around 98% of patients would recommend the procedure to their friends and family, given an average pain score of 2 to 3 out of 10. We've audited the first 100 patients that had the procedure under local anaesthetic to see who was reattended the hospital following the procedure. Everyone went home the same day within an hour of the procedure, One patient came back later in the day with some discomfort, and a urine sample detected a urinary tract infection, and she was discharged home. One patient was observed overnight because she had pain following the procedure. A swab taken only detected bacterial vaginosis, and the ultrasound scan and blood tests were all normal, and she was discharged the next morning. We've had no other complications to date, and that audit data was from 2014, so we've got quite a significant amount of data now. National data suggests for those having single-use endometrial ablation devices, the perforation rate is around 1 in 10,000 from the procedure. So there's a risk of perforation at the time of dilatation of the cervix, but once the device is in and up and running, the perforation rate is remarkably low, and there's good long-term data for these radiofrequency devices. We do still offer TCREs, which is a transcervical resection of the endometrium, and we still resect large fibroids. These are generally reserved for those with abnormal uterine cavities or large cavities. We used to do around 120 TCREs a year in our unit, and now we do less than 40. We've noticed a slight reduction in the hysterectomy rate since the introduction of radiofrequency ablation, a significant drop in abdominal hysterectomies, but an increase in laparoscopic hysterectomies, and that's just a change of practice across the UK. And more than 95% of our endometrial ablations are performed under local anaesthetic. To actually learn the procedure, it's a relatively very quick procedure, very safe procedure, and we encourage local anaesthetic where possible. Long-term data suggests that you'll have around 50 to 70% amenorrhea rates, and then another 25% or so of patients will be happy with the outcome. And the long-term data suggests between 5 and 7% of patients will have further definitive surgery, such as a hysterectomy, but the other 95 to 93% of patients have avoided the need for a hysterectomy. And obviously avoiding the need for a hysterectomy means avoiding the longer recovery time and the complications associated with that, acute complications during the surgery, but also longer-term complications with bladder dysfunction and prolapse, which can be associated with a hysterectomy.
هي بتطلع بالسيارة بالحوا؟ لا رح نوصلها مشان ما بالسيارة ايه مامي يلا حياتي اشوفهم من ورا
تعمل لي مثل لانه
Michelle, Michelle, can you take the questions, please?
well
Michelle, you are not muted. We can hear you. But let me thank Dr. Underwood. Mr. Underwood, thank you very much for a beautiful presentation and for introducing us to this, at least novel techniques, at least for us. There is a question here, I think it's from a lady from Algeria, and she's asking about what can we do if we have a cancer of the body of the uterus. We know from the TCRE that sometimes after this, this can hide any cancer of the body of the uterus which develops later. And then by the time we discover this cancer of the body of the uterus, of the endometrium, it's maybe a little bit late. What do you have any, does this technique offer any advantage in this point?
Okay, so there's some long-term data which has come out of America where they've looked at the cancer rates. So the cancer rates were similar to the background risk of a cancer rate in patients that had an ablation versus those that haven't, and the stage of disease was the same as well. So most patients present as stage 1 disease. So there's no evidence to suggest for these procedures that the cancer's hidden and presents later. The small risk you will have is it can be more difficult to access the cavity after you've had an endometrial ablation or resection. So in those patients, if they've got a cancer, generally you will be able to obtain histology because the cavity is normally been not fully ablated, so you can get back in. If they've had a long period of amenorrhea, then it's going to be difficult to access the cavity. Locally, we've had a couple of patients who have presented 5 or 10 years later with persistent postmenopausal bleeding that we can't access the cavity. We've then done laparoscopic hysterectomies on those 2 patients, and the histology came back negative on both. We didn't find any cancer. So locally, we've only got a small number of patients and we haven't detected any more cancers, but the American group have got quite large volume data and they don't identify any problems by that we're missing cancer. I think somebody asked about mini touch. I've not got any experience of using it, but it is a radio frequency device similar to NovaSure. I'm not sure of the long-term outcomes, so I can't inform you on that one. And then somebody asked about the need for Propel. So locally, we take a Propel biopsy on everyone who's having an endometrial ablation because we're doing a destructive procedure. So we should identify the pathology within the uterus that's causing the abnormal bleeding to ensure that we're not missing any hyperplasia or cancer. So that would be our local policy. But Sara and Ayman may have a slightly different policy. We'll see what they think.
Yes, our policy dictates that before performing NovaSure ablation, we should obtain a negative Propel sample.
Yeah, it's the same as us.
Within 6 months.
Yeah, so we're the same. Sarah's nodding, so I'm assuming she's in the group. Yeah, so in the UK,
Sara works with me in the same unit, so.
Okay, so UK practice would be to obtain histology before any destructive procedure. So that's the same in colposcopy as it would be in endometrial histology. So that would be standard UK practice for most units. They must use a form of contraception. So we often get asked about coils. So we do insert copper coils in patients, and we'll also insert marinas in our patients if they wish. Particularly those with adenomyosis or dysmenorrhea will find a marina may be useful for those patients, but you need to insert it at the time of the ablation. If you try and insert one 6 months down the line, the cavity will have contracted down and you'll struggle to get one in.
أول يوم 9 of December.
Dr. Michelle, we can hear you. Please unmute yourself. Mute yourself, please. Michelle, you're not muted.
Someone's asked about the anaesthetic. We use a drug called Cytonest, which is adrenaline and pilocrane mix together. I personally do an intracervical block, so I'll do it at 12 o'clock, 4 o'clock and 7 o'clock, and I'll do an ampule at each site. Some people do a paracervical block, and they'll use normally around about 30 to 40 mils of chirocane. Analgesia and pain scores are similar for both, but the complication rate with a paracervical block is slightly higher. So that's why I don't personally do it, but some people have lots of experience of using paracervical blocks, which work just as well around the UK.
There's another question about, well, we can leave the rest of the questions for the end of the session, Mr. Underwood. And it is now my privilege. I want to thank you very much for a beautiful presentation. And if we hope that your time will permit to be with us until the end, and we ask some more questions. Now it is my privilege to introduce Mr. Ayman Ewies, as I introduced him previously, and he's going to talk to us about office hysteroscopy and the from general anesthesia to see and treat. Mr. Ewies.
Thank you very much. Can you see my presentation? I shared it.
Yes, we can.
Thank you. Good evening, everyone. My presentation is about office hysteroscopy service, challenges and tips for success. First, I would like to thank Professor Sallam and his honorable committee and colleagues for this kind invitation. And also, I would like to greet my former colleagues, Abdelmajid Sarhan and Gasser El-Bishri, who are in your committee as well.
Yes.
Diagnostic hysteroscopy is the gold standard for assessing the uterine cavity. It replaced the blind and inaccurate technique, D&C, which became outmoded in the UK practice since 1980s. Routine diagnostic hysteroscopy under general anesthetic is an anachronism. We only offer it if office hysteroscopy fails or in case of patient preference. Recently, the hospital episode statistics in England during the COVID pandemic showed 70% reduction in elective theater procedures and 31% reduction in office procedures, i.e. during the pandemic, cancellation of the procedure hit more the procedure in theater, not office procedures. Therefore, to improve service efficiency, reduce backlog and waiting lists, etc., we must move procedures out of theater. The scope of contemporary office hysteroscopy include diagnostic procedures. We take directed biopsies in office, cavity assessment prior to ablation, assessing submucous fibroid to see which one to be done under general anesthetic and which one in office. Also therapeutic, we do hysteroscopic polybectomies, myomectomies, ablation, retrieval of coils, and also we treat septum. Hysteroscopic sterilization is not performed in the UK anymore. I would like to share with you my experience and our milestones. So we have done our first hysteroscopy unit, procedure in our unit in 2001. It took 10 years to develop into operative, and we have done our first Novasure in 2011, then first VersaPoint polybectomy in 2011. We replaced the VersaPoint with MyoSure in 2017, and last year we introduced Omniscope to be able to proceed with see and treat, as I will explain to you. How to set up a service? I will categorize it into why, what, who, how. So as Martyn said, the drivers are the patient choice, patient safety, shorter journey in the system, cost effectiveness. The barriers usually lack of resources or lack of expertise, old habits, protecting own practice. Most women like it. No general anesthetic, increased number of obese women and women with comorbidities in societies. Women can go back straight normal activities. No fasting, no hypoglycemia, no dehydration, no vasovagal attacks. We presented our patient satisfaction data in some congresses recently, and we handed 10 itemized questionnaires prospectively to 100 women attended our unit for diagnostic and operative procedures. And we used visual analog scale as an objective method of assessment. Actually, 93 women stated they would have the procedure again if clinically indicated in office. 97 would recommend it to friends. And all women said the staff were welcoming, supportive, the procedure was well explained, the dignity was maintained. Why we do office hysteroscopy? NICE, the body that produces clinical practice guidelines in the UK, recommend that office hysteroscopy should be offered to women with menstrual abnormalities. Vaginoscopy should be the technique of choice. And you should set up the service such that you can progress to see and treat if required. Also recently, National Day Surgery Delivery Pack guidelines in September 2020 recommended that this procedure should be moved from theater. And as Martyn said, in the UK, the practice has moved away to move this procedure in theater, but after the COVID-19, it became mandatory in centers which they don't. Cystoscopy, hysteroscopy, evacuation of retained products of conception, and endometrial ablation. How we do it? We have a unit with right atmosphere, confidence, competence, smoothness, relaxed, friendly atmosphere. We ask patient to bring with them a friend. We offer them tea, coffee. We don't use the scrubs or masks to make it as friendly as possible. One of the important things, you have to have your clear, strict referral criteria because the procedure is easier to be done in office. Sometimes the service get overused or abused or unnecessarily used, where the procedure are offered to women who don't clinically need it. So we have a strict referral criteria. So we have a venue which is fit for purpose, health and safety compatible, reception area, waiting area, consultation rooms, treatment suite with integral changing cubicle, and recovery suites with recliners and some beds. This is our unit, the reception, receptionist on the right-hand side. We have 6 rooms, 1 for scan, 3 consultation room, 2 procedures room where we do Novasure, MyoSure, 1 stop B&B, and colposcopy, and we have a dedicated waiting area. You can see on the right-hand side, the doctor's desk, sink to wash your hand, cubicle for patient to get it changed, the couch, and the equipment. This is our recovery, and you can see our recovery is slightly different from Martyn's unit, where we have recliners, and also we have beds. Occasionally patient feel faint or something. It doesn't happen often. Actually, the patient use the recovery area in our unit from 0 minutes up to 45 minutes or so. So some patients actually leave the room after NovaSure, even go home straight away. As regards patient, you have to select the right patient, the motivated one, not extremely nervous or patient prone to panic attack, well informed. They have read your patient information leaflet, already consented, had something to eat. When I do the procedure, I have a staff nurse for the equipment and 2 assistant nurses. One, the patient advocate or the vocal local, as we call it in the UK, and one to admit.
Number 1563.
What? The equipment, we have modern scopes, stacks, operative equipment, and also resuscitation facilities and emergency box are important. Severe vasovagal attacks are rare, but do occur. Complications are rare, but do occur. So be prepared. To be honest, since I established and started this unit 11 years ago, we never had any major complication. Also, if you establish a unit, you have to have your own policies and guidelines. We have our own referral pathways, our Analgesia Protocol, procedures protocol, post-operative care equality policy, patient information leaflets for every single procedure. And also our trust has moved from handwritten records. We have electronic records. Our Analgesia Protocol is slightly different from Shrewsbury. So to be honest, my tips is that I am honest. I tell the patient they will have some pain. So when the patient is mentally ready, they will have some pain. They will cope better. So the pain is short-lived anyway, and I warn patients about noises and cold saline. Also, distraction is the key. The role of the vocal local is crucial, and I let the patient watch the screen. I empower patients because before they go into the couch, I empower them to tell me stop if they want to have a few seconds of break. So when the patient feel they are in control, they cope better. Vaginoscopy for diagnostic hysteroscopy. I use the small scopes and I use low pressure. Patient cope well if they have read the patient information leaflet. I wish I could warm the saline to 36 degrees, but the nurses wouldn't let me. From my experience, anxiety is the key, not the pain. I have not come across patient who didn't like the procedure because of pain. The anxious patient who are prone to panic attack, who have phobia of a doctor or a nurse or a hospital, are the difficult one to bring into office. Our Analgesia Protocol, again, slightly different. Our patient information leaflet tells the patient to take ibuprofen and paracetamol 1 hour before the procedure. During the procedure, we give patient Entonox, which is 50-50 mixture of nitrous oxide and air, gas and air. We avoid opiate to prevent the sickness and help a quick discharge. I personally avoid local anesthetic except for NovaSure operation. I give local anesthetic only if I dilate. If I don't dilate, I don't give local anesthetic. If the patient needs dilatation maybe to 5 or 6 millimeter, I rely only on gas and air. I don't give also local anesthetic. In our unit, we don't use the focal local or fundal block. We rely on gas and air and the local anesthetic, but not fundal block. Our local anesthetic protocol, I use 4-quadrant intra-cervical block using lidocaine and epinephrine. The trick is when you do intra-cervical block is, look at the photo on the left side here. You insert the needle high in the cervix, the full length of the needle, 3 centimeter, intra-cervical, not like the photo on the right side, when you give injection superficial. The reason is the lower 2/3 of the uterus are supplied by the inferior hypogastric plexus. So you have to inject the needle high up to 3 centimeters. For the upper third, which is supplied by the superior hypogastric plexus, we rely on gas and air. The procedure that we do in our unit in office is the Novasure ablation, and Martyn kindly covered this. We also do Myosure. Myosure is the morcellation technique to remove polyps and fibroids in office. It comes in 3 different devices. One, light, Myosure light to remove small polyps, and Myosure reach to remove large polyps and moderate fibroid, and Myosure XL for large fibroid. There is Myosure manual as well, which is not connected to the fluid system. As you can see, with all types of Myosure, you need dilatation only to 5.5 millimeter, except with XL, you dilate to 6. So most of my patients who are multiparous, they actually don't need dilatation. Hence, I am conservative in using local anesthetic. It gives patient tachycardia, and in giving the needle itself can cause pain. So I'm just to try to minimize the pain. However, I'm not saying I don't give local anesthetic, but if I can work without it, will be better for patients. The Omniscope, which we introduced last year, allows us to proceed with see and treat. The Myosure device fit into the Omniscope, i.e. we do all our diagnostic procedures with Omniscope. So if you are in the uterus and you find a polyp or fibroid, you don't have to take the scope out and insert another scope in to treat. Through the Omniscope, you can put the Myosure device and to proceed with treatment. I will show you a short video about a Myosure procedure for submucous fibroid, grade note. For a patient with post-menopausal bleeding, you can see the endometrium is thin and normal. And this patient needed gas and air and also needed local anesthetic for cervical dilatation. You can see that Myosure is morcellation. It doesn't have energy with it, i.e. if there is bleeding, there is no way to stop it. Therefore, you have to select your cases for the non-vascular fibroid. Assuming if this fibroid was very vascular, for example, probably either I would have given her GnRH analog to reduce the vascularity in advance and to bring her back, or I would have booked her under general anesthetic if the fibroid is large. I would say this procedure in real life has taken 10 minutes. So I will, to save time, I will move on. The challenges of office hysteroscopy: Stenos the cervix in Liberous women and post-menopausal women, and the previous ablation. However, the main challenges, to be honest, the severe anxiety and the pre-existing pelvic pain. And the challenges for see and treat is the length of the slot, because if you book, will you book in one session 5 patients or 7 patients or 4 patients? If you are relying on diagnostic, it will take less time than see and treat. So this is one of the challenges. Also, patient mental readiness. Of course, it needs high level of expertise. Some of the solutions that we implemented to facilitate see and treat is sending patient information leaflet to patient home address before the appointment, and also telephone appointment with the nurse specialist before the appointment, so the patient get explained that they might have treatment. When you start a new office hysteroscopy unit, I have some tips, like do your first few procedures under general anesthetic, whether it is Novasure, Myosure. Even if you started to do hysteroscopy, do your first hysteroscopies under general anesthetic until you are, as we call it, you are sneaky, quick, because the patient wants to be on couch the least possible time, and they want to experience the least possible pain. So visit up and running unit, understand the technology behind your device. It will build up your confidence. Virtual reality simulation training is available. Select your patient well, select your device, develop policies unique to your unit. Patient information leaflet should be unique to your units. Follow manufacturer instructions to maximize safety. Don't try to invent your own way. Make use of your rep. They are there to help you. To conclude, the philosophy of patient ambulate in and ambulate out in modern gynecology is safe, efficient, convenient, and cost-effective. This reflects in hysteroscopy as office hysteroscopy or ambulatory hysteroscopy. It is now further developed into see and treat or one-stop service. The change in OT practice requires investment in infrastructure, training, the change of mentality of clinicians. The 80% target for office hysteroscopy should be mandatory, should be the norm. And we have to ask ourselves, can we justify subjecting women, especially those with comorbidities, to the risks of general anesthetic for a hysteroscopic procedure? Finally, no ultimate truth regarding how to set up your service. No two centers will function exactly the same way. Our way has evolved and is evolving over time. You don't have to accept all my suggestions, by the way. However, I hope you may adopt some of them though. Office hysteroscopy, can you do it? I'm sure you can. And thank you very much for your good listening. This is our lovely team in Sandwell and West Birmingham hospitals. Because of the time, I have to skip the 7 minutes video, which shows you the patient journey in our unit. Probably if there is another opportunity in the future, I might be able to present it. And thank you very much.
Thank you very much, Mr. Ewies, and again, for introducing us to something new, at least for me. And we have a couple of questions now, and then we'll leave the rest to the end. Now, we have a question from Professor Ahmed Warda from Alexandria University. He's asking about the follow-up and for how long?
Follow-up for which case? For what type of patient?
We didn't specify. Maybe, I guess, for the one of a fibroid that you have removed.
To be honest, we don't have, our follow-up rate is 0 in the variety of the procedure. So the patient with, say, NovaSure, we tell them, see how it goes in 6 months' time. If in 6 months you are not satisfied with the procedure, probably the GP can refer them back. Our data, the data from our unit about NovaSure, that 91% of women didn't require hysterectomy. 9% of women required hysterectomy after NovaSure. And the median period of duration from the initial NovaSure to hysterectomy was 1.1 years. This data is like in press at the moment, has not been published yet. So about the patient will know whether they want another procedure about 1 year after the NovaSure, but we don't follow them up, the GP follow them up. After removal of the fibroid, follow-up is not required. We write to the patient with the histology report to their home address.
Yeah, thank you very much. There is another question from Ho Fazza. I think she's asking about, she has 2 questions. The first one is, does the music have any role in analgesia? And the other one is, are you doing the WHO checklist before the procedure?
I'm not sure about the music. Maybe Sara have some experience with the music.
Well,
I don't have experience with it. Sara might answer this question. However, yes, WHO check is mandatory. Sorry that I'm not able to show you the video because I have taken longer time in presentation.
We can show it at the end, Mr. Ayman. Yeah, if you like.
Maybe, yeah. But yes, WHO check is mandatory.
Yeah, it's mandatory. Yeah. Okay, fine. Excellent. Okay, we leave the rest of the questions for the end of the webinar. And now it is please stop sharing your screen, Mr. Ewies. And now it is my privilege and pleasure to introduce Ms. Sara Greenwood, Greenaway. As I said, she is a nurse hysteroscopist at Birmingham, and she's going to introduce us to this new, for our part of the world, this new concept of a nurse hysteroscopist and what is her role and what she does actually. Please, Ms. Greenwood.
Hello. Can everybody see my presentation?
Not yet.
Might just take a few seconds to pop up.
Yes, share your screen. Yeah.
Can you see it?
Yes, but
Yes.
Yes, you can see it.
Put it on full screen now.
Yes, I will do. That's great. Can everybody see that okay?
Yes, it is okay. Go ahead.
Yes, that's great. So good evening, everybody. My name's Sara, and I've worked as a gynecology nurse for the last 20 years, and I qualified as a nurse hysteroscopist 10 years ago. I'm here this evening to talk about the role of a nurse hysteroscopist in the contemporary office hysteroscopy service in the UK, and the presentation this evening is going to focus on what I do rather than what all hysteroscopy nurses do, as our roles can vary from hospital to hospital dependent on what skill sets we have. So I'm going to go to the beginning, where the hysteroscopy course began. There was a consultant and a university course lecturer in the north of England, and they decided to create a nurse hysteroscopy course. The course was created to educate nurses in diagnostic hysteroscopy and therapeutic management, and it first commenced in 2002 and runs annually. The main aim of the course is to train nurses to undertake history taking and consent, perform hysteroscopy in an outpatient setting, to be able to diagnose uterine pathology and offer diagnosis and treatment options. And the course itself is run by the University of Bradford. So my training, what did it consist of? There was a theoretical component of my training, which was 10 days of intense study based in the university, where we learnt about the anatomy and physiology of the female reproductive tract. I then had a registered trainer at the hospital, where I had to observe 25 hysteroscopy cases. Once I'd done this, I then went forward to performing hysteroscopy under direct supervision, where you do between 50 and 100 cases, and then you go further where you do another 50 to 100 cases in direct supervision. I also kept a logbook of up to 150 of my hysteroscopy cases, and created a portfolio of 10 case studies as well. Did an audit report, and then we also had an OSCE final assessment back in the university where we were assessed by examiners. On completion of the course, I became a clinical nurse specialist in postmenopausal bleeding, where I was able to perform diagnostic hysteroscopy and endometrial sampling. Now, the course itself took 2 years to complete, and on completion, I did get a recognised academic qualification from the university. It's really important when I'm doing these procedures that I understand my responsibility and my accountability for my practice, and that I have an understanding of the risks and the benefits of hysteroscopy, its contraindications and potential complications, and also being able to deal with those complications. So being able to manage bleeding and vasovagal attacks. It's also important that I have a clear knowledge of all the alternative treatments that are available as well to the patient. So I did diagnostic hysteroscopy for roughly 6 years, and then decided I wanted to expand. So I then did some additional training to learn about the therapeutic intervention in management of abnormal uterine bleeding. And this wasn't specifically in postmenopausal bleeding that I specialise in. This was in all age groups. And again, this training was very, very similar to my original training, where I kept logbooks, had a registered trainer, did case studies, and it took me approximately another year to complete and be signed off as competent to practice. So on top of the diagnostic hysteroscopy, I can now fit and remove coils. I can do directed biopsies of lesions. I can do hysteroscopic removals of lost coils, and I also do hysteroscopic removal of polyps and fibroids via the MyoSure morcellator. So what does my role as a nurse hysteroscopist include? Well, I will perform my own nurse-led clinics and perform all of my own consultations where I will obtain full medical history. I am able to review any previous histologies, scans, any clinical imaging and any blood tests. And I also will assess that patient's understanding and make sure that they fully understand what we're doing and that they have capacity. Once I've established that a patient does have capacity, I will then obtain consent for the procedure, and I will always do this using written consent. I will perform all of my own speculum examinations and bimanual examinations, and if cervical dilatation is required, I will also administer a local anaesthesia via a cervical block. I will perform the planned procedure that the patient is with me for, and then I will take all of my own imaging and videos, and then I will record all of my findings in the patient's files. After the procedure, I will then aid that patient's recovery and check that they're okay before they go home. So we will check their vital signs, assess their pain, and make sure that they're well and they're happy and they're satisfied with the service that they've had before they leave the department. And as Mr. Ewies touched on earlier, some ladies may need to stay a little bit longer and go in our recovery area, where they will be looked after by one of the nursing team and given tea and coffee. What else do I do? Well, I chase all of my own investigations and results, and I will put management plans in place for all of the patients. I will write all of my own clinical letters to GPs, healthcare professionals and patients, and I will also refer patients to other specialities if there has been other incidental findings whilst they've been with me. I will perform all of my own telephone consultations, and I will investigate any non-correlations, and I will problem solve. So for an example, if I have a lady come to clinic with postmenopausal bleeding and she's got a thickened endometrium on scan, but I perform a diagnostic hysteroscopy and I find an atrophic cavity, I know that those two findings, then they're not correlating. So I will then go back to the sonographers and I will ask them to review all of their imaging to ensure that the measurements that they've given me are correct and that there's been no typo errors on the reports. It's also important when I'm doing all of my own procedures that I identify my own limitations and my own competencies. And I will always refer on to my clinical lead consultant, Mr. Ewies, when patients are out of my clinical competence for advice and guidance. So that could be ladies that have got complex medical history, obesity, poor mobility, capacity issues to consent. And then if there's poor access that I'm really, really struggling, I will always pass that over to a consultant. So what are the qualities of a nurse? What do I bring to the table? I think nurses act as a key link. So we will provide effective communication between patients, the nursing team, doctors and other healthcare professionals. And I'm able to combine the advanced practice techniques that I've learned in my hysteroscopy training with the traditional nursing skills that I've learned over the years to maintain that nurse-patient relationship. As a nurse, we always offer a patient-centered approach, and we will counsel our patients with compassion and empathy, you know, with good listeners. We will provide any information that the patient needs, and we will support their decision making, but we also promote continuity of care. What's the additional benefits? Well, as a nurse and a nurse hysteroscopist, I'm reliable and I'm flexible, but I'm also quite diverse. So I will offer additional nurse-led clinics to meet service demand. And then I can also cover consultant absences as well. So if one of our team, one of our doctors, they're in an emergency or they're running late for clinic, I'm able to start the clinic for them to prevent any delays of the patients being seen or cancellations of those patients. I will also cover the annual leave as well, or any sickness from one of our doctors. And I will also supervise the trainees. As a nurse, I don't always have to be a clinician in clinic. I'm also able to step into that clinic as a nurse and support that doctor and the patient through their journey. As a nurse, there's also the cost benefits as well. We're cheaper than doctors, so nurses are economical. So what's my additional roles? What else do I do? There's also quite a bit of administration that we do behind the scenes as well. So I will triage the referrals that come through to the department, and I will check their suitability to ensure that they are placed in the right clinic with the right clinician. I'm also able from the referral to pick up any patient needs, extra needs that we may need to put extra facilities in place. So if we've got a lady that's got mobility issues and needs a hoist, or we've got a lady that's got an IBMI and needs bariatric equipment, or a lady that may need that little bit of extra time in clinic, I'm able to pre-plan that before the patient actually arrives. I will also refer to and participate in the multidisciplinary meetings and prepare the meeting to ensure that all the patient information that we need is available so that that meeting will run smoothly. I will help perform audits and update the policies and the protocols alongside Mr. Ewies and the other doctors, and I will review patient satisfaction and expectation. We review the service performance as well, and as nurses we will work with everybody else in the team to embrace change and improve that service delivery and efficiency. So ongoing development, what else do I need to do? A nurse hysteroscopist is a speciality that's been achieved through the advanced study programme that I've talked about. We have to attend annual general meetings, AGM meetings, and I also attend masterclasses with medical companies to ensure that I'm up to date with all the latest technology and research. I have to hold an up-to-date knowledge on all the policies and the guidelines and the research-based practice that we do. And I also review my own performance. Nurse hysteroscopists in the UK are recommended to be a member of the British Society of Gynecological Endoscopy. And also, I have to look at my nursing element of things as well. As a nurse, I have to be a member of the Nurse and Midwifery Council, where I have to do 3-yearly a revalidation process with them, as well as completing the mandatory training as well to meet the hospital requirements. So what do I get out of it? Well, I'm extremely lucky because I absolutely love my career choice. Nursing is completely in my blood. I have that personal satisfaction of nursing patients and providing care. But I also have the professional satisfaction that I'm a valued member of the team, and there's a lot of respect and trust within our hospital and within our division and our department. I'm very lucky because I have a fabulous nursing team and administration team behind me, as well as all of the other consultants and doctors that I work alongside. And I'm very much supported by all of my nursing colleagues and by Mr. Ewies, my clinical lead. And I'm very much led by his experience and his expertise. I just want to finish off by saying that nurses have a desire to learn. And we love the professional growth and the educational development that we can have because nurses are evolving continuously. And I'd like to think that I can still grow further. And I've got an interest that I can maybe expand in what I do and in the future learn to do endometrial ablation with Mr. Ewies being my teacher, my registered teacher. I just want to say that nurse hysteroscopists are experts in our own fields, and we absolutely love what we do. Thank you so much for listening.
Thank you very much, Ms. Greenaway. This was a beautiful introduction to the concept of nurse hysteroscopist. There's a question here from Dr. Ayman Jamil. He is very impressed. And he says, how long did it take you to, how long did it take you to how, I think you doing a very good job. For how long did you train to be well qualified? I think
I started my gynecology nursing career 20 years ago. And then I started my nurse hysteroscopy training in 2008. So I completed it in 2010. It took me 2 years to complete. I then practiced diagnostic hysteroscopy for about 6 years before deciding to expand and go down the therapeutic element. And like I said, that took about another year to do. So I've been doing therapeutic treatments as well as diagnostic treatments now for about 2.5, 3 years.
Yeah, this is, thank you very much. I think we will leave the rest of the questions for the end of the session. And thank you very much, Ms. Greenaway, and stay with us because we have these questions at the end. Thank you very much. Thank you very much. Now it is my great pleasure to introduce my colleague and our former head of the committee, Professor Amr Elnoury. Professor Amr Elnoury, as I said, is Professor of Obstetric Gynecology in Cairo University. He is both an FRCOG and FRCS, and he has the MD on top. And he is going to talk to us about the safety issues in hysteroscopy in fertility in general. Professor Amr, the floor is yours.
Professor Sallam, can you hear me?
Yes, we can hear you. Can see your slides.
First, thank you very much, Professor Sallam, really for the invitation. And it's really my great pleasure to join you with my dear friend, Professor Michelle Abu Abdallah. And also great pleasure to see this actually experts from UK, Professor Martyn and Professor Sara and Professor Ayman Ewies. Actually, I started training in endoscopy and hysteroscopy 30 years before now. In 1990, I used to work with Ray Gary. He was the president of the British Society of Gynae Endoscopy at that time. And then also this was at James Cook University currently. And then I had the opportunity also to work with Professor Ed Shackstead, who also was fond of endoscopy at that time. So really, this is the way I started developing hysteroscopy and also endoscopy. So hysteroscopy in fertility really is very important. We heard a lot of things about it, but I'm going to stress about some of the safety issues, and some may be actually related to Egypt as well. Can we have the questions for the audience? It will be a few questions. We can have really like a quick poll for this. It's also
Paul has
great.
started.
Can we have Sumaya, please?
Yes, Paul has started.
Okay, so because we don't see it, they see it, yeah?
Yes, we can see the questions, Professor.
Okay, maybe because I'm sharing the screen, so, okay.
Yeah.
And they shouldn't take a long time, the questions really, they are very quick, I can see Professor Sallam, a lot of friends from UK and from the Middle East in the audience, so it's
yes,
nice.
in fact, I want to take this opportunity to welcome Professor Victor Gomel. Professor Victor Gomel is the former professor in Vancouver in Canada. He is the first IVF in the whole of Canada. But before doing this, he was actually a world expert in endoscopy, laparoscopy, and hysteroscopy, and he's watching us from the far west of Canada. Welcome, Professor Victor Gomel, and thank you very much. He's the former president of the International Society of IVF. I can see his name.
Welcome, Professor Gomel. Right, I think we can actually, do we have the poll? Can you see the poll or?
Yes, people are voting. It's now 195 who answered.
Okay. Right, can we get the results now or?
Yes, sure.
How can I get, I don't see it.
Yes, we can see it now.
Can you see it, Dr. Amr?
No, I cannot see it, but it's, okay, I can go through it and then.
Can you stop screen, share screen? I think you can see it when you stop it.
Okay, so that's fine, thank you. Right, so if I, okay, no, I can't see it yet. I don't know why I can't see it. Okay, I go back again, so. Right, can you see my screen now or?
Yes.
Okay. Right, as we know that diagnostic and operative hysteroscopy now being used for a very long period of time, and we can see that they are having a great success and also low complication rate relatively. So it is a relatively safe procedure, but it's of paramount importance to always consider the safety issues to avoid the potential complication that can happen from this apparently simple procedure that can be really a disaster after that. And these are the potential complications of hysteroscopy. You can do uterine perforation, the pain and the dissatisfaction of the patient, the fluid overload and hyponatremia and its consequences, the hemorrhage, embolism, infection, and you can get litigation and sued very easily with these procedures. So the incidence of abnormal hysteroscopy findings in infertility, actually nearly 40%, they can have abnormal findings. And the younger the patient, the less the pathology, but the older she's getting, it can be up to 60% of pathology in the. These are the contraindications that one should really not do hysteroscopy. If active uterine infection, systemic illness, one should make sure that she is not pregnant, and sometimes with the heavy uterine bleeding. However, nowadays with the good fluid management system, you can do it. These are the abnormal findings we can find in infertile women. Intrauterine adhesions, you can have polyp, submucous myoma. They act really like a foreign body within the uterine cavity, preventing pregnancy. You can have a septum, or sometimes there is a chronic retained products of conception, or chronic inflammation, or micropolyps. And one of the important things really is to take a valid consent from the patient. And we have actually the Royal College, they have its consent advice, so you can go easily and follow the main points, if you don't have a specific consent in your hospital. The hysteroscopy setup, I think all the speakers, they talked about it, so I'm really not going to talk about the dedicated outpatient hysteroscopy service and appropriately sized and the rest and the staff and so on. But really, it's very important for the safety to know your equipment and be familiar with all your equipment, how to assemble and disassemble the endoscopy, and make sure that they are the right equipment before you start the procedure. And you have either the general gynae equipment in the form of dilators that should be really each half size, and the hysteroscopic equipment starting from the diagnostic to the mild surgical to the more complicated with either the resectoscope or the morcellator. And also you have to be aware of the other equipment and how do they function, especially when you work in places that you don't have the full backup as happened in the UK, including the electrosurgery or the energy sources that you are having and the camera and the light source and everything really. So it's very important to complete your procedure. And very important is the positioning and the comfort of the patient. And we always do it in the dorsal lithotomy position. But again, in office hysteroscopy, usually it is a short, so there is no problem about the perineal nerve. But if you are going to use for a longer period, the procedure, and as we know that the procedure has to be short really in all cases. Awake patient better to position themselves to avoid the low back ache that sometimes can be a problem, and the patient sometimes can sue the hospital or the doctor for having a back problem after the procedure. I'm not going to talk about the anesthesia as the speakers, Professor Ayman, he talked about it as well, And I really thank you for the speaker for talking about the vocal local, because I believe that this is really very important, that the vocal reassurance of the patient is much, much better than any of the anesthesia that we give. So one of the problems is the perforation, and it is actually range from 0.007 to 1.7%. And it is unlikely to occur in vaginoscopy when we go directly into the vagina without dilating the cervix, and you just really follow your path and your pathway through the negotiate the endocervical canal. So it's unlikely to do this with the vaginoscopy. However, with operative hysteroscopy, it can be around 1.6. And of course, it is more if there is cervical stenosis, tortuous cervix for whatever reason, and distorted uterine cavity, for example, from myoma. And most of the perforation occur at the time of entry, similar to the laparoscopy. And the rest is due to the improper use of the energy source and the probe of the energy source, whatever the energy source is. So sometimes we can actually give misoprostol to make the cervix a little bit easy for dilatation, to by manual examination to know the size and also the direction, whether it is antiverted or retroverted, because most of the perforation occur in extremely antiverted or extremely retroverted, or we can use it by ultrasound if we are not, if we're doing hysteroscopy. But again, this with the vaginoscopy and office hysteroscopy, it is unlikely to be a problem because you negotiate your own way. We should never use the sound. The sound can cause perforation, and if you use a dilator used as a pin grip and you just go to the internal os, you don't go more than that. The vaginoscopy, you follow the angle of the lens and you have to move the camera very slowly and the scope as well very slowly. And very slowly in order to allow time for the fluid to distend the cervical canal and also the uterine cavity, and also to interpret and also to, if you go slowly, then you avoid perforation. You have to identify the tubal ostia, and because once you identify it, you know that you are really within the uterine cavity. And even if you go out, then you go inside again, you have again to identify the tubal ostia to make sure that you have not perforated anything. And if you are going to use any energy source, you have to always to see the tip of the probe within the field of your work, and you only activate the energy while you are withdrawing. And I dare you to do a post hysteroscopy. So really looking at the tubal ostia, it's very important to look at it at the beginning of the procedure. And when you do any energy source, you should keep the energy part within view all the time, and you just activate it while you are withdrawing. So these are very important safety issues to avoid injury or perforation. And again, with the type of hysteroscopy, the outpatient hysteroscopy, we use the smallest hysteroscope possible. Now we have very good view and high quality and high resolution. And so we have the 2.9 millimeter telescope, and we have the outer sheath of, or the sheath of 3 to 3.5 millimeter. And this you can go actually through the cervix very easily, even in nullipara, even in virgin patients, we can use this very simply, because in Egypt, virginity is very important, so we can use it in some of the cases. Negotiation of the cervix and knowing the angle, whether it is 0 or 12 or 30, and then you can translate this in what vision of the tunnel of the endocervical canal. If you have a 0, then you see the whole tunnel equal, but if you have a 30 degrees, then you should see only the upper half of the endocervical canal or the uterine cavity. Again, you have to enter very slowly. The distension is very important, safety, and we have mainly saline or glycine 1.5%. Some use CO2, but again, we have to know that the CO2 has a special distension or insufflator that its maximum is only 100 ml per minute, unlike the endoscopy one, which can be, the minimum is 1 liter per minute. The pressure during the procedure, in addition to the vocal local, if we have less than 30 millimeter mercury, then we will not see very well, because we know that the uterus is a potential uterine cavity or a muscular cavity, so you need to distend it. So less than 30 millimeter mercury will not let you see well, but the appropriate one is 50 millimeter mercury, because you can have better visualization than the 30 millimeter mercury. But if you go more than that, then it will start to cause pain and discomfort to the patient. So this is very important to keep an eye on the pressure. And if you are going to do surgery, then you need something around the mean arterial pressure, which is around 75 to 90 millimeter mercury. The fluid can become absorbed from either the fallopian tube into the peritoneal cavity or through the opened venous channels, or when you open, for example, the fibroids and you start to do resection. So the more you have high intrauterine distension pressure, then the more that you will get increase in the fluid deficit. And also, if you go deep into the myometrial penetration, then this will happen. That's why in myomectomy, it's better not to cut through the myometrium, and only you cut through the myoma. If you have a large uterine cavity or prolonged surgery, of course, we can see here the pressure increased gradually, and then when you start from 80 millimeter mercury and more, it starts to go very, very fast, and you have a fluid deficit very quickly, and this is very dangerous. The problem with the distension media is the fluid overload. You will get hyponatremia, pulmonary edema, cerebral edema, scissors. And of course, the risk increased with the hypotonic solutions, the physiological or non-electrolyte like the glycine, but so one has to be very careful about this. And this is actually the recommendation of the British Society is if you have a fluid deficit more than 1,000 ml, this should be the threshold to define the fluid overload when you have to stop the procedure. And if you are using near physiological solutions like the normal saline or the ringer, then the fluid deficit of 2,500 ml should be used at the threshold. So this is very important. And while we are doing the procedure, we have to monitor the fluid in and out, and then calculate the fluid deficit. And you have to stop if you reach the threshold to avoid the pulmonary edema, which can be actually lead to death if we are not sure. Well, hysteroscopic myomectomy, one of the problems that it needs advanced training and high level of expertise, and it is in the RCOG level 3 of hysteroscopic surgery. But it's very important for you to remember the classification of the submucous myoma. We have the 0, which is nearly into the uterine cavity completely, and 1, which is more than 50% within the uterine cavity. And you can know this by the acute angle between the endometrium and the wall of the uterus, myoma. And you have the type 2, which is most of the myoma is within the muscle, and you will have an obtuse angle between this and that. This was the British Society and the European Society also for gynecological endoscopy, but the FIGO put some more. And I want you to draw your attention to group 2.5, where that you can have part of it looking as a grade 2, but again, the rest is reaching to the outer surface. So if you remove the myoma, you will perforate the uterus. And this is very important to know this by good ultrasound prior to the procedure, and maybe MRI if you are not sure. So this is very important in doing as a safety for. So as I mentioned, we have several energy sources, starting from even laser to monopolar to bipolar to true clear to MyoSure to resectoscope to VersaPoint. So one should be acquainted very well with the instrument and how do they function and how you assemble and disassemble, and the safety point and the importance of the fluid monitoring while doing the procedure. So the rules, if you are going to do hysteroscopic myoma, is to open the pseudocapsule, and you don't cut through the myometrium, because our late Professor Ala Shafiq from Egypt, he always actually taught us that the myoma protrudes proud of itself. So once you open the pseudocapsule, it will start to go into the uterine cavity more. So it changed from grade 2 myoma to grade 1, so it will be easier. So it comes to you rather than you go directly. And as I mentioned earlier, you keep the tip of the electrode, whatever energy source you are using in the field, and you activate it while you are withdrawing. The uterine septum is very important sometimes in infertility, and scissors is safer than electrosurgery because we know that most of the septum are fibrous. So if you cut it with the scissor and you start to get bleeding, so you know that you reach it to your limit and then you have to stop. So otherwise you will go into the myometrium and then you can do perforation, and you don't know if this is a bicornate uterus or double uterus or just really a septum. Of course, the ultrasound and the 3D ultrasound will help you, but this is very important. If you use only electrosurgery, then you will lead to coagulation, and then you coagulate into the muscle. So you think that it is part of the septum, but it is actually going into the muscle till you find that you perforated the uterus and went into the uterine peritoneal cavity. The laser holmium, it's used actually in prostate surgery, and it has a beauty that its only depth of penetration is only 0.5 millimeter depth, and it only works in close contact with the water and the tissues. And it's very important that we do a post-hysteroscopy procedure check to identify unsuspected perforation, look again at the tubal ostia, and you can suspect the perforation if you have a sudden loss of vision, the uterine cavity collapses, you cannot see anything, and there is bleeding, and also there is loss of the anatomic landmarks, which is really one of the most important things. Even if you go back again, then you have to look at this. The cleaning, draping, disinfection, sterilization, a very important safety. We cannot make it a sterile in the outpatient, and also in the vagina, you cannot sterilize it, but you can disinfect this, you can clean it. But again, the disinfection of the equipment and the sterilization of the equipment, and we know that we have different types of fluid or sterilization, like the glutaraldehyde. This is for the rapid one, but also you have the plasma, which have a short cycle of around 30 minutes that you can sterilize plastic things, or sometimes the scopes, because the temperature does not exceed 45 degrees, or the ethylene oxide, which is really not started to stop using nowadays. A very important in endoscopy and hysteroscopy is the training. We know that hysteroscopy is easy to learn more than the in laparoscopy, but still there is a learning curve, and you need a lot of manual dexterity. We have been actually using with the International Representative Committee, doing many workshops in hysteroscopy. We've done more than 25, I believe, hysteroscopic workshops so far. And first we start with a workshop, and the workshop you learn the eye-hand coordination, which is very important, how to assemble, disassemble, how to hold the camera, how to move slowly, how to negotiate the cervix. We have our nice models for that. And then you can go for animal lab when you start to do some electrosurgery, for example, or energy sources. In this case, you move from the eye-hand coordination, you move to the eye-hand foot coordination, where you are actually pressing the pedal at the same time. And then we have now the virtual simulation or real simulation, which is computerized. And this you can have different types of the procedures, and you can have an objective structured assessment. If you touch at the wall of the uterine cavity, if you how many minutes it took for you, the fluid deficit, so all this. And the last one is the operating theater. And this you can learn with your consultant, and then the consultant should help in teaching this, because if someone really actually did this one, then litigation can be very easily if the consultant is not present. So, and before operating on this patient, really, then the trainees should be assessed, and they should have an objective assessment recorded in the trainees logbook. So Ari, one stop here, and we can take the question answer. And I can see many of those who answered, for example, the fluid deficit, some actually putting the 750 ml, some protocols for the hypotonic solution like the glycine, and some put the 1000. So, but again, you should not exceed the 1000. For the normal saline, some put 2000 ml at the threshold to stop, and some put as 2500 ml. So both answers really are right, but you have to be aware of the fluid deficit while you are working, and then you have to inform the anesthetist. And probably sometimes you can ask the anesthetist not to give the patient much fluids before you start the procedure, so to avoid the fluid overload. Thank you very much, and Professor Sallam, the floor is yours.
Thank you very much, Professor Amr Elnoury, for a beautiful reminder of all the safety issues in hysteroscopy. Now we have a few questions for the esteemed panel of speakers. So can I start with one of them is, what's your way to dilate the uterus in the cervix, I guess. It's the uterus inlet. This is from Dr. Basant Mohammed. I think maybe Mr. Underwood can let us know.
If this is dilating the stenosed cervix, so we just use mini scopes and we always manage to get in. So we don't use misoprostol locally. I'm not aware of a great deal of evidence for it, and I think the others are shaking their heads. I can see at the top of the screen anyway. So generally we can get in. Cervical block is useful. Use a smaller scope as possible and use hydrodistension. So you're using the fluid on your scope as you're entering the cavity for most patients. If that fails, we have a green soft os finder that we can use that can open the cavity. And then very rarely we'll use a white needle just to open the cavity, and then an os finder, and then use the hysteroscope after that. And then I tend to get all the fiddly cases. So we do get the odd patient where you have a completely stenosed cervix where they've had a LETS in the past and the skin has almost grown over the cervix. Those can be more fiddly to manage. So you may sometimes do a LETS procedure just to open up the surface of the cervix, and then you can generally find a canal and proceed from there. But those, I probably get one of those a year or something. So they're quite rare that happens in the UK practice. And it was more common in the older patients when we used to do knife cone biopsies after they'd had a cervical CIN. But that's quite old practice now. We don't tend to do knife cone biopsies very much in the UK anymore. So most patients you can get in. It's just being patient and tolerant.
Yeah, thank you very much. There's a question for Mr. Ewies. What are the medication used for intracervical anesthesia? I guess. You're muted. You're muted, Dr. Ayman. Still muted. Yes.
Lidocaine and epinephrine.
Yeah. So that's what
lidocaine and epinephrine.
You use. Okay. There's a question for Professor Amr Elnoury. Why is scissors better? I didn't hear well. Well, maybe you can repeat it. Yeah.
Okay. As I mentioned in the septum, that if you use electrosurgery, it will cause coagulation. And coagulation will give you like a white color. So you don't know if this is the muscle or if this is the septum. So you keep going, so cutting through the muscles and coagulating the muscles. And then all of a sudden you find yourself into the peritoneal cavity. But with the scissors, because we know that the septum is usually fibrous, so you can cut it, and when you start to get bleeding, then you know that you reach it to the muscle where you shouldn't really cut. So this is a safety, and I've seen actually this case with myself before, you know, that going very nicely with the needle part, you know, with the diathermy, and you are happy and everybody praising you, and then all of a sudden you find yourself into the peritoneal cavity. So the scissor, you cut only the fibrous part. When you start to bleed, you stop.
Yeah. Oh, thank you, Professor. I think there's a question for Mr. Underwood. If we remove a polyp for a lady who wants to become pregnant, after how many months can she get pregnant?
So I'm not a fertility expert, so I'll let Prof. Amr answer that one. I would personally suggest at least 3 months to allow the cavity to heal, but I'll see what Prof says. Just a question on the paracervical block. So if we do them, we don't do it very often. We use a drug called chirocane, which is levobupivacaine, because it's safer if it gets into a vessel. So you can get less cardiac arrhythmias, whereas if you use lignocaine or lidocaine, then you can get cardiac arrhythmias if some of it goes intravascular. Whereas chirocane, you get less side effects from that one. But I'll leave one of the fertility experts to answer you about the polyps and fibroids.
Yeah, you want to say something, Professor Amr or Professor Ayman?
I think if it is a polyp, really, it is 1 cycle or 2 cycles, the endometrium will repair itself very easily and nicely. And the problem, if someone is doing myomectomy or removal of a fibroid and damage the muscle itself, this is the problem. Then you have to stay longer, you know. But if you just remove the myoma, shelling the myoma with no damage to the myometrium, I think 2 months or maximum 3 months would be fine.
Yeah.
I give the same advice for grade note polyp or fibroid. They can get pregnant straight away. There is no limit as long as you don't dig into the myometrium. However, For grade 1 and grade 2, I advise them for 3 months.
Yeah. All right. Thank you. There is a question, I think, for Mr. Underwood. What is the failure and incomplete rate in office hysteroscopy?
So we've audited our data. We run this audit every year. So our data is persistently below 5% for a failed hysteroscopy. Our rates vary, so it's 1.2% was the lowest failed rate. We went up to 10%. 2 years ago, we had a locum consultant who joined our trust and he had a failure rate of 24%. So he didn't stay with us very long, but generally it's below 5%. And a lot of this is the same as laparoscopic surgery and vaginal surgery. Have a small cohort of people doing lots of those operations rather than lots of people doing a small number of the operations, and you become better at that procedure. And with it being an ambulatory procedure, you need to have a consultant that's going to be chatty to the patient. So it's the vocal local, you need to distract that patient. Some of our colleagues don't like talking to patients, and if you're sat between her legs and you don't speak to her, she will experience more pain and she will be less complimentary about the care she receives. So you do need to be able to have a good rapport with the patient and the staff around you.
Yeah, and I guess this the failure and the failure and complete rate depends on the experience of the operator. I guess it's
yeah, it's the same as when you train in colposcopy. So your depths are always 3 or 4 millimeters when you do your first few lets, and then you slowly get a bit deeper. So it's practice makes perfect, they say.
Yeah. Another question from Dr. Hassan Elbis. In one sitting clinic, I guess he means a one-step clinic, diagnose and ablate option. What is your incidence of endometrial hyperplasia and cancer? And if any, what is your assessment markers, if any, are there any assessment markers prior to the procedure that will alert you and might help you to do a biopsy before ablation? I guess this is the question. For yeah, maybe for all the panel, maybe.
Yeah. So in the post-menopausal group, the risk of cancer detection for all patients referred to a PMB service is about 5 to 10%. Cancer and hyperplasia grouped together. In the premenopausal group, it's less than 5%, and the main risk factors for both are obesity being the main risk factor, unopposed estrogen, so if you have an HRT patch alone, and then diabetes, hypertension, polycystic ovaries. Those would be the main factors, but obesity is the big one. So we'll have BMIs of 60 plus in some patients. Probably about half of our patients will have a BMI over 40 that are coming through our service, but for PMB in particular. I'm not sure what Ayman and Sara say, but I suspect the national figure is it should be more than 3% for it to fall into the routine referral on the 62-day cancer pathway, your detection rate.
Sara, would you like to add something?
Just that I completely agree with what my coach just said.
Yeah, and Ayman, you want to say something also?
I think his question means, do you take endometrial biopsy before NovaSure ablation? If I understood the question correct, and both Martyn and I we agreed that the protocol, you have to get negative endometrial biopsy before you perform NovaSure ablation. In our unit, we mandate the biopsy is taken within 6 months of ablation. So this is the first part of the question, I think. The second part of the question, if I understood it correctly, what about accessing the cavity after NovaSure ablation? So we have done a small exercise in our unit, which you presented, I think, in ESCI in Budapest some years ago. We have about 16 patients, all postmenopausal, who had ablation in the past and presented to us with postmenopausal bleeding. Actually, in these 16 women, we managed to access the cavity in the 16 of them. So we had no single patient that were not able to access the cavity and diagnose whether cancer or no cancer. The problem is not to diagnose or not able to diagnose cancer. The problem is the easy pathway of diagnosis, like the diagnosis become more difficult because we rely in diagnosing or management of postmenopausal bleeding on transvaginal ultrasound scan. If less than 4 millimeter, the endometrial thickness, we do nothing else. If more than 4 millimeter, we do Propel sample. So it is difficult to assess the endometrium properly with the scan, and outpatient Propel sample might be difficult. So the patient will end up having the whole workup as hysteroscopy and the curettage under general anesthetic. So what we found in our cases is not that we are not able to diagnose, is we converted the simple office procedure into procedure under general anesthetic, but this is minority of patients, and it's worth being exposed to general anesthetic to rule out cancer.
Sure, of course. Anything to add, Professor Amr Elnoury?
No, I would agree with the...
Yeah, I'm sorry I took over from Professor Abu Abdallah because he had some problems in his connection. I don't know if you have been able to read the questions, Professor Abu Abdallah, or did you? Are you muted? You probably are. You are muted, Professor Abu Abdallah. Yeah. You want to? Yeah.
Well, I've seen the question. The problem was the sound.
Yes.
I couldn't follow the sound properly.
Yeah.
Because of. However, I have seen the question, and most of the important question, I saw that you went through it, Hassan.
Yeah.
What I didn't like about the question, that those who put anonymous participant, so those I skipped, because there is no anonymous. We're not in Hollywood here. We're in a webinar whereby we can ask freely our questions.
Yeah, but
otherwise, the questions that you mentioned are really the most relevant and important one.
Yeah, because one of the questions from an anonymous person was, is it really ethical to give general anesthesia for some time just for the sake of training? This was for Dr. Ewies. But yeah. I have another question. Yeah, somebody asked about the any role for GnRH before hysteroscopic removal of fibroid. Do you give GnRH routinely? GnRH agonist, I guess. Yeah.
The first part of the question, I think it is entirely ethical to expose patient to anesthetic for learning curve, because this is for people who have no expertise in their unit. They have not built up a unit yet, right? So you have to balance what we call ethical versus safety. You can try to be too ethical and compromise safety, which is not correct. However, in unit which is up and running, like with Martyn in Shrewsbury or with us, we train trainees right away to do the procedure under local anesthetic. But if you don't have such a setup and such expertise, you shouldn't compromise safety. And safety is to try under general anesthetic until you have a team or cohort who are able to do it in office. So it is entirely ethical in that context.
I agree with you very well, but since Professor Abu Abdallah opened the questions, all right. And what about GnRH agonist before fibroid removal?
Well, I don't use it personally before MyoSure treatment, but I use it in two indications. One, in the very large fibroid, like if I have submucous fibroid 6 or 7 centimeter, I use it before I do resection. And also I use it for the very vascular fibroid. Sometimes you see dilated blood vessels on the surface, etc. I think this will be annoying and will not make the field clear during the procedure. So I use GnRH analog in such cases. The third indication in which I use GnRH analog, the patients who are hemorrhaging. I have a group of patients who sit on the fibroid for a long time and they get admitted to us to the ward with hemoglobin of 5 and 6. So, and they keep bleeding. So I have to stop the bleeding first to be able to build up hemoglobin and give them iron or whatever, blood transfusion, whatever they will have, to be able to do the procedure. So these are the indications. So I think I'm a bit not liberal in using it, but I have specific indications.
Yeah, before asking the same question to Mr. Underwood, I guess Sara has the same practice as we are working in the same practice, aren't you? in the same hospital. Yeah. But
Yeah.
my question was, you said that if you have a patient with vascularity, increased vascularity, you mean this is seen by 4D ultrasound or ultrasound beforehand, huh?
No, diagnostic hysteroscopy.
Huh?
Diagnostic hysteroscopy.
So you have that. So you mean, but this is not treat and see and treat then?
Correct. When we all patients start with office diagnostic hysteroscopy first. If you have a fibroid that is 6 or 7 centimeter vascular, she is not suitable for office work.
Sure.
So the patient has to be optimized and prepared and booked for general anesthetic.
Yeah. Okay. And same question for Mr. Underwood. Do you use the GnRH agonist?
Yeah. So for our see and treat patients, so we aim to have a one-stop clinic. The GP refers them. We'll see them a couple of weeks or a couple of months later, and we'll offer a hysteroscopy. And if we see a fibroid 3 or 4 centimeters, we'll use an outpatient resectoscope. So we use MyoSure, there's True Clear, there's a Stort scope out, there's different ones. So we'll resect all of those. And in that group, we wouldn't use any Zoladex. But the same as Ayman, if you get the one that comes in really heavy bleeding, needing a blood transfusion, we'll give a Zoladex for a few months, take a biopsy, and then we'll bring her back and resect it at a later date. Anyone having a TCRE under a general anaesthetic, they have a 1-month injection of Zoladex for 3.6 milligrams. And if they've got a large fibroid, we may give Zoladex for 2 or 3 months to try and shrink the fibroid a little. And then we would do a resectoscope on that group of patients. So we do use it occasionally. The outpatient resectoscopes, there's different ones on the market. They don't tend to bleed a great deal with those. Tends to be quite a quick procedure. Some small polyps may take you 10 or 20 seconds to remove, and a 3 or 4 centimeter fibroid, some will chew through in 5 minutes, and sometimes you'll be there for 20 minutes going through them. It just depends on how calcified they are, how hard they are, as to how quickly you can get through them. But Zoladex is useful, particularly as Ayman said, if they come in bleeding a lot, because sometimes you try and hysteroscope them and you can't see a great deal. So say Zoladex for a few months, take a biopsy to make sure there's not a cancer there that's causing the bleeding. And if there's a cancer, then it's an easier decision. It's a hysterectomy in most patients if they're fit for it. But then the other Zoladex to bring them back.
Yeah, thanks so much. Professor Amr Elnoury, what is the usual here in Egypt? Do people use GnRH? Do you use GnRH liberally?
Well, depends really on the economic or financial status of the patient, but it's one of the options, especially if you have one who having severe anemia from severe bleeding. Then I think this one, usually the Zoladex is the best treatment for these cases, and usually give 10.8 milligrams subcutaneous. And after 2.5 months, then you can go and do the procedure. But sometimes I go for bigger fibroid. And this is why sometimes we give misoprostol, that because you try to cut the myoma into smaller pieces, and then you try to remove it as bigger pieces through the undilated cervix. But with the misoprostol, it will help to come out easier in these cases.
Yeah, thank you very much. I think we have 2 more questions just before finishing off.
Dr. Hassan, there is one comment, about the GnRH analog. Bear in mind, when you use GnRH analog, that there is some reports, and I personally encountered 2 cases, that it makes cervical dilatation difficult in some women.
Yes.
So especially if you are using it in women with already stenosed the cervix or Liberous. So I faced a situation twice that even under general anesthetic, I wasn't able to dilate the cervix. This has to be borne in mind before a liberal use of GnRH analog.
Can I ask you, Professor Ayman, do you find difficulty when you use Zoladex, for example, to find, to clear the myoma from the pseudocapsule? Because we know that if you do normal myoma.
No, because I use bipolar resectoscope, not the traditional monopolar resectoscope that urologists used to use with glycine. The new one is used with saline, and it is bipolar, and as long as it cut it, so it is not difficult to reach the plane or to find it. Just you keep cutting through.
Yeah. All right. Fine. There is a question about, do you use the hysteroscope for sterilization? Any experience in that? I guess in the past they used to block the ostia by certain different procedures. Do you do this in the UK? Are you still anybody doing it in the UK? Any experience?
We used to use a device called eSure made by Bayer.
Yeah.
That was taken off the market maybe about 3 years ago. So it wasn't taken off the market because there were any problems. Apparently it was a commercial decision by Bayer to remove it from the market. I think they do still sell it elsewhere in the world, but in the UK and Europe, I think it's withdrawn. And I'm not aware of any device that's been released that replaces that in the UK. And I personally liked eSure. It was a great device, very quick, very efficient. I'd do 8 or 10 patients within 2 or 3 hours because it was so quick. But there has been some negative media around it. So there's some potential risks there.
I believe the main problem with it, or one of the main problems, is when you do laparoscopic sterilization, you tell the patient you are now safe from today. However, after hysteroscopic sterilization, they have to wait 3 months and do hysterosalpingogram. So this could take 3 months, I think. I'm not experienced in it, but that's what this is the way. So women don't like it. They want to have the procedure to be secured the following day.
Yeah, so it's 3 months later, and we did an ultrasound scan for all of ours. You could do an abdominal X-ray, and you got the McDonald's sign, was the other way of saying if they're in the correct place. And then if they failed on the ultrasound scan, then it was a HSG to see if the tubes were blocked. But it was 3 months. But then it was all done while they're awake with ibuprofen, in and out quickly. Whereas a laparoscopy, you had to have a general anaesthetic and complications associated with that. So there were risks and benefits of both, but sadly Bayer withdrew it from the market in the UK probably 2 or 3 years ago.
Yeah, is it reversible?
No, it's permanent, and it's got Dacron in the middle, and that encourages tissue growth through the middle of these coils. So it's nickel and Dacron, the graft, and then the tubes were fully occluded with it. And then if you try and remove them, you'd end up doing a hysterectomy in most patients because they snap and they were difficult to get out.
Yeah. There's a question from Algeria, Dr. Ali Sedrati. He's asking about, do you give any antibiotics after operative office hysteroscopy? No. Yeah. Okay. And the other question is the optimum fluids and pressure during the procedure. I think Professor Amr Elnoury has spoke about that. Then if this is the case, I have a final question for Sara. And yeah, right. Because I'm an IVF man. So during embryo transfer, maybe 15 years ago, there was a study, a randomized study in Oxford, and they started asking nurses to do the embryo transfer. And it turned out that the nurses were better than the doctors, actually. And yes, and for many reasons. But you see, how did they know? They knew because of the pregnancy rate. So they compared the pregnancy rate. They found that the pregnancy rate was better when the nurses did the embryo transfer. So my question here is, how would we have, in the case of hysteroscopy, do we have any benchmarks to go around? I mean, you train the nurses, and then how do you know they have become efficient? Is there any benchmark we can use? I mean, in our case, it's very common now in the UK to do embryo transfer by nurses. I think most of them are done by nurses. But so, is there any benchmark, or does it just?
I think when it comes to nurses doing hysteroscopy, it's not so much that there's a benchmark. We work very, very similar to the consultants. So we will review our practice just like they will. So we will look at our failure rates, how many ladies that have been more challenging, that have needed to go to general anaesthetic. But it's not just a failure rate that it could be that you're unable to dilate. In an outpatient setting, you've got that anxiety as well and the pain, and that can also hinder your success rates. But it doesn't mean that technically that we're any better or any worse than the doctors. I think we all have our pros and our cons, and yeah, we all work pretty much similar.
Yeah. Right. So if this is the case, then I'll pass my microphone to Professor Michel Abu Abdallah, who I'm sorry about the issues he had. Maybe he would like to finish off the webinar. Michelle. You're muted, Michelle. You're muted.
Okay.
Yeah.
I'm okay.
Yeah, okay now.
I would like to thank you, Professor Hassan,
Thank you.
for allowing this webinar to happen. Secondly, the webinar was very interesting. I would like to thank the speakers, who all of them from their sides contributed to the education of our colleagues here in the area. Thank you all, and looking forward to have you in another conference.
Thank you very much, Michelle, and thank you very much again for all the speakers. Mr. Martyn Underwood from Shrewsbury, Professor Ayman Ewies from Birmingham, and Sara Greenaway from Birmingham, and from Cairo, Professor Amr Elnoury. Thank you very much, and we hope to see you in person and to have a similar meeting in Cairo and in Alexandria, to see you in person and do the real thing. Thank you very much, and à la prochaine, as we say in our part.
Bye-bye.
Bye-bye. Bye-bye. Bye-bye. And thanks for the audience, and thanks for Merck for sponsoring these events. Thank you.
Thank you, Professor Sallam.
Okay, Amr Bey.
Okay,
All right.
pleasure meeting you, Ayman, Sara, and Andrew, and Professor Michelle Abu Abdallah.
Thank you.
Michelle, and yes, and Booster Bees, of course. Big thank you for your technical support and everything.
And for Merck
Mr. Underwood, thank you. And okay, I think everybody has disappeared except Professor Ayman Ewies. Ayman, I will be in touch with you to thank you again and again. And Amr Bey, I will phone you tomorrow to leave you to this week. Okay, bye-bye.
Thank you, everybody.